Доброе утро, добрый день, доброе очень раннее утро, например, в Канаде и ближе уже к доброму вечеру в других частях света. Я рада приветствовать вас на нашем втором дне заседания сети «Регионы за здоровье». И перед тем, как я передам слово двум сопредседателям, я хочу сказать, что у нас есть несколько целей. Первая цель – это обзор текущего статуса. Вторая цель – это лучше понимать, какая реакция и какие меры дополнительно сейчас требуются от систем здравоохранения, а также понимание того, как мы наилучшим образом можем двигаться вместе и взаимодействовать с сетью «Регионы за здоровье» и как мы лучше можем подготовиться к условиям текущей пандемии и к возможным будущим пандемиям. У нас вчера очень успешно прошло первое заседание. Если нет каких-либо возражений, которые касаются программы, похоже, что возражений нет, отлично. Тогда я хотела бы передать слово моим двум сопредседателям, точнее не моим сопредседателям, а просто сопредседателям. Прежде всего хочу дать слово Камиле. Пожалуйста, вам слово. Пожалуйста, представьтесь и представьте вашего сопредседателя. Большое спасибо. Большое спасибо, Беттина, и большое спасибо всем коллегам в Москве за то, что вы организовали это замечательное, интересное и очень важное мероприятие. Конечно, я также хотела бы находиться в этом прекрасном зале с вами в Москве, но я к вам подключилась из Норвегии. Меня зовут Камила Илебек. Я являюсь профессором общественного здравоохранения Норвежского университета естественных наук. И также я являюсь членом руководящей группы сети «Регионы за здоровье». И я буду сопредседателем на протяжении сегодняшнего дня вместе с моим коллегом Андреем. Андрей, может быть, вы также представитесь? Good afternoon, dear colleagues. My name is Andrei Grigorov, and I'm head of the Organizational and Analytical Department of the Moscow City Health Department. And I'm happy to welcome all the participants here in Moscow at this session. Thank you, Camilla.
Yes, thank you. Nice to see you, Andrei.
Спасибо, рада вас видеть, Андрей.
Also very much welcome to all the participants joining in for this
участников, которые присоединяются к этому
Now,
заседанию.
Bettina just went through the objectives for the day,
сейчас
so I won't
упомянула
repeat
цели нашей
But
работы
let
на
me
сегодняшний
provide you with a
день. Я их
brief
еще
overview
повторю.
of the day,
И хотелось бы
because we have a
также
lot of things
кратко рассказать о повестке на сегодняшний день,
on the
потому что
program.
нам предстоит
We
сделать
have
много
now
всего.
first 1 hour of
Итак,
plenary.
сейчас у нас состоится пленарное заседание, которое будет длиться 1 час, и у нас будет 6 презентаций, и затем сессия вопросов и ответов. Если у кого-то есть какие-то вопросы или комментарии, то, пожалуйста, вы можете их направить через чат, и мы постараемся ответить хотя бы на некоторые из этих вопросов прямо во время нашего заседания. Далее у нас будет очень короткий перерыв, 5 минут, и затем мы разобьемся на 3 параллельные сессии, и вы должны были получить отдельные ссылки для того, чтобы зайти в эти панельные сессии. Они также содержатся в программе. Модераторы панельных сессий, мы их позже представим.
Back from the work streams to a plenary session following that. And 3 key takeaways from the groups are then provided. And then we will, after the different tracks, we will reconvene in plenary and we will have a presentation from Canada and we will have some key takeaway messages. So that's the program for the day. And then I think with no more messages that we need to give, we need to get on with the very interesting program that we have. And I would then like to introduce our first speaker, which is Mrs. Tanja Schmidt. She's with the WHO Euro technical officer there, and she will be speaking to us about the impacts of COVID-19 and public health measures. So Tanja, please, the floor is yours.
Thank you very much, Chair. Thank you very much for the opportunity to provide a short presentation on PHSM implementation in the European region. I have a few slides prepared, which I will be sharing now. I hope you are able to see them.
Yes, we see them now.
Great. Okay, then I'll start. Hello, everybody. My name is Tanja Schmidt. I'm a technical officer based at the Health Emergencies Program in the WHO Region Office for Europe in Copenhagen. And with this short presentation, I would like to provide you with an overview of public health and social measures that have been implemented in response to COVID-19 in the European region, based on data reported to WHO by member states, as well as based on data systematically collected and coded by the Health Emergencies Program. I will then shortly proceed to outline some of the tools that have been developed by WHO, which are available to your network to use, which may aid in the decision-making process of PHSMs and communicating about them. But just to start, and as a reminder, this slide illustrates the situation as of the 25th of October. And as you can see, over the past 14 days, WHO has recorded an increase in cumulative cases as well as cumulative deaths in the region, 5% and 2.5% respectively, with the United Kingdom reporting the highest proportion of all cases in the WHO European region, followed by the Russian Federation, Turkey, France, Spain, and Italy. You can see here on the right-hand side as well that the proportion of cases reported in the European region, which is the green color, has been increasing in the past weeks as well. When it comes to public health and social measures, first of all, really want to emphasize that we're speaking of a package of interventions that countries, regions, and communities have been implementing to reduce transmission and slow the spread of COVID-19. WHO has classified them broadly into 8 categories that are outlined here on the left. It is important, however, to note that PHSMs should not be equated to what is often referred to as lockdowns. They're much more than that and include individual measures such as wearing of masks, performing hand hygiene, to surveillance and response measures, including contact tracing. So it is really a comprehensive approach that is necessary, as no single intervention can prevent the spread of disease on its own. As we all know and have experienced ourselves over the past 1 to 2 years, there are of course a lot of challenges associated with PHSM implementation. Some of them are listed here on the right. And relate to, for example, decision-making with regards to timing and communicating on PHSM, uptake and adherence to PHSMs by the population, especially due to pandemic fatigue, decisions with regards to level of enforcement. It is also a balancing act between the level of PHSMs to be implemented and the economic and health system impact. And then, of course, addressing the mental health impact and consequences is also an issue, and you will hear more on that from our next speaker. As you can see on this slide, this is just to give you a snapshot of key public health and social measures implemented in the region. Countries are taking a varied approach, where we see 12 countries as of this week that are easing PHSM restrictions, curfews or lockdowns, and 19 countries that have intensified restrictive measures, often due to a set of different categories, including epidemiological situations, hospitalization rates, or excess mortality. We have also recorded 44 countries that are currently implementing so-called COVID-19 certificates to show proof of vaccination recovery and or negative tests in order to facilitate the access to institutions, businesses, services, and schools. This illustration provides a really nice overview of the PHSM response across the WHO European region as of last week. And data is based on 6 key areas of measures that are listed here on the right that have been coded in order to come up with a severity index. So the darker the color, the more severe the restrictions. And again, you can see here a lot of patterns emerge, different waves of PHSM implementation, illustrated by the darker color, the beginning of the pandemic, and then during the winter period of this year. And then more recently, overall relaxation of a lot of the measures as vaccination uptake has increased. Variation is also quite clear here on this slide when we're looking at individual PHSM categories. So we've just listed those 6 key measures again, and again, the darker the color, the more severe restrictions in the region across member states in the region. And school closures is a very nice example here, as you can see, especially at the beginning of the pandemic, very severe restrictions, school closures across the region, which then have been really lifted, especially when coming into the new school year, with really aim at having school closures as a last resort, and instead of that, adding preventive measures that would allow in-person teaching. Just very quickly also to highlight some of the tools and information dashboards that are available to you, developed by WHO. We have, of course, our COVID-19 dashboard platform, which visualizes the data. We're about to launch a more interactive, user-friendly database where you can access information by country and by PHSM category. So this is about to go live very soon. And these are publicly available websites. And then finally, we have developed a set of operational tools, frameworks to help and guide decision-making at the national level, but also at the regional local level. One of them is the so-called PHSM calibration tool, which supports decision-making on the PHSM that should be implemented based on a situational level that is assigned to a country based on the epidemiological data, as well as public health capacity. When it comes to international travel restrictions, there is an operational framework available that has been published the past weeks for your consideration as well. But I'll stop here and looking forward to the discussions. Over to you, Chair.
Thank you very much, Tanya Schmid, for your presentation. We will have the Q&A session after all of the presentations, and now allow me to give the floor to Melita Yakab, head of WHO Almaty office in Kazakhstan, and she will speak about the role of primary health care in response and recovery of COVID-19. Melita, you have the floor. Thank you very much.
services. On this side, you can find the link to our vignettes. We're very proud of this because we feel that it's our duty as WHO to document the massive transformation happening at primary healthcare level. And this engagement with countries has shown us how much adaptation has taken place during the pandemic. And it's really inspiring and gives us hope for a lot more action in this direction after the pandemic. So I would like to share with you a few 4 or 5 high-level messages on what kind of changes we are seeing during the pandemic and what are the commitments that member states have made during the regional committee. The first one is that we will never go back to the world where primary healthcare is only delivered in facilities. In the pandemic, we have seen that countries are using multiple platforms, and this will remain in some kind of balance after the pandemic. Some services to some populations will be delivered face-to-face in the facility, but we have seen an increased use of mobile services that take primary healthcare services, diagnostics, lab tests, and specialist services to the people, to their home, and deliver face-to-face services there. And of course, the third one is remote delivery of primary healthcare services through a large number of platforms. Here, there is no magic bullet, and a key question is, how do we prioritize, how do we balance what populations and what services can be best delivered in what kind of settings? The second transformative aspect we're seeing is a much accelerated shift toward multidisciplinary teams, which are connected together to networks. And we have seen an expansion of primary healthcare teams through the addition of psychologists and social workers in particular. This is very significant because this enables primary healthcare to move closer to the ideal that was expressed in the Almaty and Astana declarations to address root causes of illness. Instead of treating the child with antibiotics several times during the winter, understand why that child has pneumonia so frequently and address the housing condition, the employment conditions, and the social conditions. This is a very dramatic acceleration. Of course, we started before the pandemic, but we are seeing the recognition of its importance during the pandemic and a commitment to move towards this in the future. Related to that, there was a dire need to identify and reach out to those people in the community who are considered to be high risk and vulnerable. And not just high risk and vulnerable from the perspective of a specific disease or health condition, but more comprehensively considering their physical health, mental health, as well as social conditions. Strengthening the capability of primary healthcare to identify vulnerabilities in a complex manner is a big opportunity. And with digital solutions, with strong risk stratification mechanisms and strong data, we have an opportunity to leapfrog and progress fast. What even more exciting is what we saw during the pandemic, and we'll speak to you directly, is that primary healthcare centers were working together with non-governmental organizations, NGOs, community and local governments to deliver not just health services, but a broader range of social and mental health services, often beyond the specific terms of reference or scope of practice afforded in legislation. And this is very important because we saw that even if many private and even public organizations were unable to function, primary healthcare was closest to the people and their partner during the pandemic. What I describe here shows that primary healthcare of the future will be a much more complex entity than the primary healthcare of the past. And that means a new approach to leadership and management. We need to connect practice to policy. We need to connect community level, local level, and regional level practices and innovations to national level policy making. That requires distributed leadership and leading from behind, and give a voice to those who are actually sitting in the front line. There are some conditions for sustainability. Investing in the primary healthcare workforce is number one in terms of ensuring adequate numbers, adequate work conditions, fit for purpose education, and health and well-being support. When we went to the regional committee with this narrative about the future of primary healthcare, we asked the 53 member states participating, where do you see the most powerful opportunities to accelerate the strengthening of primary healthcare? And you can see the right part of this slide that basically all the themes I mentioned before were equally high rated. The future is in enhancing prestige, it's in multidisciplinary teams and networks, it's tools to identify high-risk vulnerable, it's task shifting, advanced nurse roles, new paradigm of health workers, education, etc., etc. And this is all very good and well known. We have lots of very strong national primary healthcare strategies. But what we see is a very big implementation gap between our ideals and what we know and practice on the ground. And here, regions and communities have an enormous role to close the implementation gap. In this year, we have begun to explore with countries that we consider quite successful in strengthening primary healthcare. What are the factors that lead to successful implementation? And there are four: political commitment at national, regional, and local levels, an enabling environment for innovation and change, introducing change management know-how, changing complex systems requires skills and knowledge, and generating evidence to feed the process. And what can be important roles here is to develop governance linkages between national and subnational levels, engaging people and communities in the design of services. Governing primary healthcare by standards, rigid standards, is the past, and tailoring to local needs, local circumstances. For example, the composition of multidisciplinary teams is really the way to the future. It's very important to channel the voice of practice to policy to ensure that the national policy frameworks reflect their needs. It's important to create partnerships with non-governmental organizations and non-state actors. It's very important to identify and invest in agents of change and leadership. And finally, we need to measure results and celebrate success. So to end, we would like to take a poll with you who are doing this on a daily basis in your regions, communities, and cities. Where do you see powerful opportunities in your region to strengthen implementation mechanisms for primary healthcare? You can go to www.menti.com on your computer or on your phone, or you can simply scan this QR code on the right-hand side, and you will see the option to rate these 8 different opportunities that I just highlighted. Please let us know, do you think this is a small opportunity, not so important, or do you think this is a big opportunity? I will give you 2-3 minutes to do this, and then if the chair gives me 1 more minute, I would like to share with all of you the results of your vote for food for thought.
Okay, thank you, Melita. I think 2-3 minutes is a bit too much, as you have used your time already, but maybe if people can be very quick to answer to the poll, we can get some results.
No, that's excellent. So perhaps you would like to continue, and after the next speaker, we can pull up the poll results, and that's a more efficient use of time. Is that all right with you?
That is a very good idea. Maybe also we could have it at the end. So
yeah, perfect.
Yeah, that
perfect.
would be fine.
Perfect.
Thank you very much, Melita, for this very interesting presentation, and also very exciting to have a poll, which is nice. And now we'll invite our next speaker, Dr. Ledia Lazzeri, to take the floor, or rather the screen. Ledia Lazzeri, she's a regional advisor in mental health at WHO Euro, and she will be speaking to us about the impacts of COVID-19 on mental health and actions to take. So please.
Thank you. I am trying to share my screen now. Okay, just a second, please. Where is my? Excuse me, just one. Yeah.
Yes, now we see your screen, but not the presentation.
It's the wrong screen. You see the screen now?
We see the screen, but not your presentation.
How about now?
Now we see it.
Okay, perfect. Thank you. So thank you very much, and hello, Camila. We have met before in another Regions for Health network, and I was in another position. And hello, colleagues and friends from the Region for Health network. As I was introduced, I am the new regional advisor for mental health in the WHO Regional Office for Europe. I have taken duties in May this year, when it has been, and I have been kind of swept off my feet due to the unprecedented attention and action in mental health that is happening, and it's due to COVID-19. The attention of policymakers, communities, health professionals on mental health has been uniquely highlighted, and it on one hand, while we try to mend our wounds because of COVID, we're also trying to capitalize on this attention and mobilize resources and policy actions on mental health. Our vehicle for action in mental health in Europe is the Pan-European Mental Health Coalition, which is a body that was just established less than a month ago in Brussels, and I'll talk a bit about that. But before going to that a particular body, I'd like to remind us what is the basis for the Mental Health Coalition. Do you see my the next slide?
No, I don't think so. We see the what to and how slide.
Yeah, do you see this now?
Yeah, now we see.
Beautiful.
Yeah.
Thank you. So the basis for action for the Mental Health Coalition is the newly endorsed European Framework for Action on Mental Health. It is its timeline is from today to 2025. And it follows the logic of the global WHO Global Program of Work and of the European Program of Work. And it focuses around the three main pillars, main strategic objectives, that is moving towards universal health coverage, protecting people better against health emergencies, and ensuring healthy lives and well-being for all at all ages. How does this translate in mental health? How those strategic priorities translate into mental health? When it comes to universal health coverage in mental health, we talk about mental health service transformation. And we want to, within this framework, we want to promote and to support our countries to improve self-care and management as that enables people to live in the community, people and their carers, for an active and autonomous and meaningful life in the community. And we also talk about transferring mental health from exclusively hospital-based settings to community and general healthcare settings like primary healthcare. We just heard Melita giving a beautiful presentation about. And last but not least is about strengthening mental health care through long-term care and support. And this is something still painful in not only in WHO European region, but around the world, because we know very well how our older adults population, especially those that were living in institutions, were particularly affected by COVID, both in terms of their physical health, and they were exposed to higher death rates, but also their mental health was particularly vulnerable due to isolation and cut off from the rest of the community. When it comes to protecting people better against health emergencies, the next strategic priority, what we hope to achieve is integrating mental health into the emergency preparedness, response, and recovery. And the picture there that you see on that pillar is the typical picture that you usually see in emergencies is WHO people taking care of dispersing, of disseminating medical supplies, in this case, vaccines or protective equipment. And we are working with our member states to make sure that next time we have an emergency, mental health is part of that emergency response. And you will see a picture there that comes from Ukraine, where community-based mental health teams were visiting people at home to deliver mental health care in absence, following what the transformation of services amidst the pandemic. And the last one, but again, not least, is how do we ensure well-being for all at all ages in mental health? It means that we promote and protect mental health over the life course Particular focus will be given to children, adolescents, and young people because evidence showed that they were particularly affected, exposed, vulnerable to the pandemic-related restrictions and changes, as were older adults. I briefly spoke about, but they for the same reason, they are identified as the second, together with children, adolescents, and young people. Older adults are identified as the second focus of the other focus of our work, not second in rank, but the other focus in our work. Of course, work will continue to focus on suicide prevention. It's an unfinished business in WHO European region. Some of our member states have still very high suicide rates, and we are working on that. And last, again, but not least, is mental health in the workplace. All of us were aware not only of how health workers were particularly exposed, vulnerable, subjected to the overwhelming working conditions due to COVID, but also mental health in the workplace in general was tremendously affected because of job loss, because of precarious working conditions, etc., and so on and so forth. Now, how those three priorities, you see here in this diagram, there are three big circles that represent the three strategic priorities I went through. So how the coalition will work to make that possible, how they will work with WHO to make this possible. And you see, we have the three big circles that represent the three strategic objectives. And then we have WHO at the center as a secretariat that has been entrusted by the member states to take this forward. Who do we work with? And you'll see who do we work with is the little other blue circles. We start with governments, of course. Our member states we are accountable to, and they are part of this action through the appointed technical focal points. Each member state has provided an appointee to WHO to take part in the coalition. We have international organizations such as our UN partners, UNICEF, IOM, but also international organizations like international partners like European Commission, and not only. We have mental health experts. We have individuals across the region, either as affiliated to academic institutions or as experts in their own rights. And they, in our work, are organized within the Technical Advisory Group for Mental Health Impacts of COVID-19 that is contributing evidence and recommendations to WHO in these times. And the fourth partner that is as important as the other three is civil society. We have big non-governmental organizations like, for instance, Mental Health Europe, Alzheimer Europe. These are huge organizations at the European level, but we are also interested into smaller organizations that can that have a say, that have an influence, that have resources, have a mandate to contribute to their local communities. Now, how
I'm sorry, Lydia, your time is running up, so
I will go very fast. How shall we approach? How shall we work with those partners to make sure those strategic objectives are met, are answered? First of all, through advocacy. Second, through mental health literacy. Those others are the ones that I'm talking now. Third, through leadership. And when we say leadership, it's not only leadership among policymakers, but leadership at service level, leadership at community level, leadership at civil society level, and so on. So leadership at a very wide basis. And very importantly, data. We do not have a harmonized data collection procedure across the region that focuses on both mental health status of the population, but also mental health system performance. And we are working with all those partners to go towards the development of the creation of a mental health data lab in Europe. And Chair, do I have 1 more minute?
No, I'm sorry. I have to
Okay.
stop. I have to stop you now.
With this,
Sorry
if
about
you
that.
allow me 3 seconds only. With this, I hope that partners who are listening to this conference feel encouraged and motivated to join the Mental Health Coalition. And please be on the lookout in the WHO website, where you will receive instructions on how to do so. Thank you, Chair, and apologies for the time.
Спасибо большое. Извините, что вынуждены прерывать,
Thank you very
но
much. We are very sorry indeed that we had to interrupt you, but unfortunately we have to be very strict about the time. So please do not take more than 7 or 8 minutes. Try to
Петр
stay
Хоске,
within that time frame. And now I would like to
представителю
give the floor
Европейского
to
бюро ВОЗ,
Peter Hoske. He's the
с докладом о
representative
роли
of
единого
WHO
здравоохранения в
Euro.
готовности
He will
к
be talking
пандемии.
about the role of One Health for future preparedness and response.
Thank you very much, Mr. Chair, and thanks for inviting me to participate in the meeting today. I should have my slides on the screen now. So I'm Peter Sousa Hoysko. I'm the Technical Officer for Food Safety and Zoonotic Diseases, based in the WHO Regional Office. I'm also the coordinator of the internal One Health working group that compiles different technical programs working with the One Health approach. And that's exactly what I will be talking about during my presentation today. One Health, the approach to address health threats in the animal-human environment interface. I will introduce the concept, I will outline some of the benefits and the challenges of implementing a One Health approach, how to operationalize it, and some suggestions on what can be done at regional level to better operationalize and use the One Health approach in a more systematic way than what we've done in the past. So, first of all, many of today's health threats require multi-sectoral responses. It's not one sector alone working, and the COVID pandemic is a very clear example of how the importance of health, agriculture, veterinary services, environment working together to address a health issue. So it goes for pandemics like COVID-19, it also goes for zoonotic diseases, antimicrobial resistance, food safety, environmental contamination, climate change, and many others. This is not an exclusive list, but the One Health approach can be addressed or be applied to many different health issues. It can even go beyond infectious diseases, and some people say you can also apply a One Health approach to non-communicable diseases and so on. But basically, the purpose of using a One Health approach to better understand the root causes and the interconnected drivers that lead to disease emergence, spread and persistence, to better understand why these health challenges come up and how we can better prevent and respond to them. We need structured solutions with a greater focus on the upstream prevention measures, and to better integrate the capacities and the resources that are available within the human health sector, the animal health sector, and the environmental health sector. As Dr. Tedros, DG, mentioned it, health or human health does not exist in a vacuum, and nor can our efforts to protect and promote it exist in a vacuum. The close link between human, animal, and environmental health demand close collaboration, communication, and coordination between all the relevant sectors. And the relevant sectors, mostly human health, veterinary services, and environment, but in different countries and at different levels of the country, at national level, local level, or subnational level, there can be different sectors that are relevant to involve. So it's really important also to take a tailored country-based approach when One Health is being applied. So what is One Health? This is a definition, I think still the official definition by WHO, FAO, and OIE. But that being said, there has just been a new definition proposed, and I wouldn't include it here because it's a very lengthy one with explanatory notes. But it basically says the same as what we have here. Not to say that just replicating. There are some new features to what One Health really means. But in essence, I think it's nicely summarized here as an approach to designing and implementing programs, policies, and legislation and research in which multiple sectors communicate and work together. It's not about everybody doing everything together. It's about dividing roles and responsibilities between the relevant sectors and acknowledging that working together can have benefits, and basically saying 1 + 1 is 3 rather than 1 and 1 is 2 when two workers are working side by side. So what are some of the benefits of applying the One Health approach? First of all, it's about promoting a shared vision and coherent and coordinated action to address these multi-dimensional or multi-sectoral health challenges that we are facing. It's about having joint prioritization, putting resources together and coordinating who is doing what. It's a very effective and is also a sustainable and cost-effective solution to manage some of these health threats that are associated with the interaction of humans, animals, and the environment. Sometimes different sectors have different priorities, working in different directions, and sometimes being counterproductive to one another. And that's where the One Health approach comes in and brings them together for prioritized strategies and resource allocation and mobilization. And it's a good way of clarifying who's doing what, when, and where. However, it's not always easy. And I think everybody working with the One Health approach will agree that it looks nice on paper, but implementation can be very, very challenging. It requires strong political cooperation and support. It requires resources, flexibility in the way resources are being allocated and mobilized. It requires skills, and not least, it requires incentives. If there's no incentive of working together, people will not work together. So good intentions can show to be very difficult to translate into joint planning, budgeting, and implementation. And in many cases, ministries are structured in their different ways. They're working more or less in parallel with different reporting lines and different budget lines. And as long as that's the case, it's very hard to create the incentive and the motivation for working together and sharing resources. And as I said earlier, it has to really be tailored to country and regional level, as no size fits all. So how can we operationalize a One Health approach? Yeah, we can first of all focus on the interdependence of the human, animal, and environmental health, and focus on the health issues that really requires joint action and coordinated actions across the various sectors. We need to take measures to address the gaps and the overlaps that exist in the current structures. And we need to map out who is doing what, where and when, and how we can better complement as opposed to overlap and repeating what others are doing. We need to scale up the investments to reduce the threats and provide early warning systems to also improve the response and multi-sectoral response when and where emergencies, infectious disease, even pandemics, when they may arise. So what can be done by the regions for health and others? Yeah, we need to institutionalize the One Health operational structures and to establish better multi-sectoral coordination mechanisms with the relevant structures, with an appropriate reporting and hierarchy of power, not ministry by ministry or sector by sector. We need to strengthen the awareness, the cross-sectoral competencies, and the governance structures, so those reporting lines become clear and respected. We need to incentivize and facilitate the behavior change and institutionalize that behavior of working together, and sharing information is not, often information is being seen in the same way as power, and many people don't want to share power. So we need to kind of facilitate that behavior change and acknowledgement that sharing information can be to the benefit of all. We need to integrate.
Could you try to finish now? Yeah.
That was my very last slide.
Thank
we
you.
need to integrate One Health into the curriculum of health professionals. It's a lot easier for young people and young professionals to work with the One Health approach than the very experienced ones that have been on the labor market for many years. And then we need to allocate investments and capacity building efforts where the health gains are biggest, and also do joint risk assessment. So with this, I will hand it over to you, Chair. Thank you very much.
Thank you so much, Peter, and sorry to interrupt you. Our next speaker is Mr. Tom de Buck. I hope I said that correctly. He's the head of a section of specialized and primary care, Flandern's Agency for Care and Health. And he will be speaking to us about their experience in primary care reform process and vaccination.
Yes.
Please, Tom.
Thank you, Chair. Hello, my name is indeed Tom de Buck. I will share the presentation, just a moment. Yep. Voila. I'm head of the Department of Primary Care and Specialized Care in the Agency for Care and Health. And the next, I hope, 10 minutes, I will give you a short overview of the biggest drivers of the Flemish vaccination campaign. First of all, I'll present the timeline for the reform of the primary care, because it's important to show how the COVID crisis hit the newly established 60 primary care zones and their boards, and how we used it as an opportunity. Secondly, I will give you the main drivers in a short time, the success factors of the vaccination campaign in Flanders, and the role of the primary care, of course. And finally, we'll take a little step into the future. Is there still time? It all started in 2010 with the conference Primary Care, and by means of a sort of bottom-up approach and consultation of all kinds of experts, major guidelines were selected. For example, a shared care and support plan, neighborhood care, more prevention, care coordination, etc. The primary care, and you see them on the right side above, the primary care zone is a sort of geographical description of an area with approximately 100,000 inhabitants. It's important to stress that care providers and local authorities work together and develop their care and services together. So in a sort of bottom-up approach, in close dialogue and co-creation with every stakeholder, we ensured that Flanders was finally divided into 60 primary care zones in July 2020. Within the governance structure of the primary care zones, the Care Council, different partners are brought into dialogue with each other. And 6 months later, in December 2020, we were commissioned by the government to set up 95 vaccination centers in Flanders. It was the day of Christmas Eve that we organized our first webinar, just to give the signal to all our stakeholders that we were on top of it and that we would give information the first week of New Year. Also to cool them down, because they were over-enthusiastic. So together with the primary care and the primary care zone, we were able to install 95 vaccination centers in February the 15th, just on 6 weeks. It's amazing how fast we were able to do that, thanks to them. It's important to give you the objectives of the vaccination campaign in Belgium and in Flanders, because they're important to know, because they define all our next steps in the organization of the vaccination and the systems we built to execute. First, and the most important objective, was to reduce mortality. So we started to vaccinate from old to young. We started, secondly, vaccination of people at health risk and also the health professionals. The second objective was to avoid overburdening of the care system, and finally, also hoping to restart social life. We divided it in 3 main stages. So stage 1A was the residential care, the plus 85 years old and the health professionals. Stage 1B were the 65, the people of 65 years and older, and the people, the high-risk patients, so patients with underlying comorbidities. This selection was possible on the basis of the data of the sickness funds. And in stage 2, we ended with the whole population. On the next slide, you'll see the different phases. I put them on a timeline. I'm sorry, it's in Dutch, but it's quite clear. So stage 1, we started in the beginning of January, end of December. Stage 1B, March, and stage 2, the end of May, the beginning of June. You'll see we have a very high percentage of vaccination. Approximately 93% of our population above the age of 18 plus is vaccinated. Almost 96% for the people who are plus 65 years old, and 81% for the whole population. This was quite a global success for Flanders. I will give you in a short notice the most important building blocks of the vaccination campaign, because they're quite important. We started with one central registration, or the national registration number for every citizen. It made it possible to select people on age, and also link every citizen to his vaccination center based on his zip code. Also, the use of the central registration made it possible to report via dashboards, and also to construct the vaccination code database. The vaccination code database is very important because it's allowed us to tag people and to prioritize in vaccinating order. Secondly, there is already an existing basis for vaccination in Flanders. It's also important. Thirdly, we made specific choices in the distribution process. So we didn't allow people to choose their vaccine. And we, from Flanders, from the government, decided how much vaccines every vaccination center got. There was no free choice. We used, like stressed in the beginning, the power of the local organizations, so the primary care boards and the local authorities. They were very eager to work together, to collaborate, and to reach our goals. And it's thanks to their installation in July 2020 that they already knew each other and were able to work together. Fifth, accessibility is a very important factor for the vaccination. From the government, they allowed to install 120 vaccination centers, so 2 for every primary care zone, but we landed on 95 vaccination centers who were operational in 6 weeks. A specific allocation model was designed for the distribution of the vaccines according to the specific population entitled for a vaccine, the capacity of the vaccination centers, the availability, and the type of vaccines. We centralized the steering by the Flemish government, so everything from supply, invitations, choice of the selected group was done by the Flemish governments. We also sent digital invites, the web portal we used, Mijn Burgerprofiel in Dutch, but also letters on the classic paper form. We had one central place for all communication. It's still live, so you can see www.letyourselfvaccinate in English, laatjevaccineren.be. It's a portal for citizen professionals, daily updates, figures, and all info. We installed a dedicated team of regional coordinators for the vaccination centers. And we installed a specific governance and a stepwise approach in function of the different stages in the vaccination strategy. We had a large involvement and awareness from all the partners, and a vaccination code database is very relevant. So we, based on the national registration number, we built another vaccination code database based on age, but we could also tag people as care professional or with a comorbidity. We could prioritize, we can adjust vaccine type. By example, for age, it's a very big step, this vaccination code database. And last but not least, we were supported by external partners like Möbius and DXC. Möbius was very important because they helped us with logistics and distribution. That was not my kind of expertise. Summarize, these were the seven...
I'm sorry. Yeah, now we are attacking you from all parts of the world. Could you please try to finish?
Yes, this is the last slide. So in the future, we will use this experience to expand a population management in care, well-being and prevention, with government functioning as a platform, with a local management of the invitations, with a booking system they can use, and specific dashboards, so well for the citizen, the care provider, and the government. Voila, I'm going to close here. Thank you.
Спасибо большое.
Thank you very much indeed. Now allow me to give the floor to my colleague, Elena Hafkina, who is Deputy Head of the Moscow City Health Department. She will speak about the measures that were taken in Moscow to tackle COVID pandemic. Elena, you have the floor.
Добрый день, уважаемые коллеги. Очень жаль, что мы не смогли всех приветствовать.
Colleagues, good afternoon. It's a pity that we couldn't welcome you here in Moscow in person. The weather is lovely today.
Видно мой экран?
Can you see my slides?
Андрей Александрович, видно мой экран?
Andrei, can you see my slides? Yes, everything's perfect.
Итак, Москва – один
Okay.
из крупнейших мегаполисов
So,
мира.
Moscow is one of the biggest cities in the world. What is it? It's 12.7 million of population, 25.1 million of tourists per year. And we have a lot of neighbors, the region of Moscow, the region of Ivanovo, and we have 3 million people migrating from the region of Moscow into Moscow every day. We have 238 medical institutions, and we hospitalize over a year 2.2 million patients. We offer our services to 610.4 thousand foreign citizens. We have 105 persons per thousand of people per polyclinic. Today we are living through the fourth wave of the pandemic, and by the end of the week we'll have probably the biggest infection rate. Moscow was the first city in Russia who faced COVID pandemic, and we were the first to take all the waves that came with it. So what helped us through the first three waves? And we hope that we will be able to face the fourth one as well. Well, of course, we try to use all the systems providing for the organization of the Moscow operation. Of course, no one can stand the pandemic on their own. We created the first COVID hospital at the end of January 2020, before the pandemic, and then we created a clinical committee to organize the operation of medical institutions during the pandemic. There we gathered the experts in all the domain, the immunologist, allergologist, pulmonologist, therapists, general practitioners. They all come together to develop new methods, methodologies, and operation rules. Then, of course, we were supported by the administration. They helped us to organize visits to patients. They were issuing the medical certificates and sick leave documents for those who had to isolate themselves. And, of course, we were supported by the Department of Information Technologies to improve and quickly transform the information system of the healthcare system of Moscow. Then the Department of Transportation provided us with vehicles to, again, organize visits to patients and to provide transportation for medical professionals from their homes to hospitals. The Department of Housing, together with the Department of Construction, helped us to quickly finish the construction of ongoing the ongoing construction of hospitals and build new hospitals as well. Of course, Moscow lives within the overall system that covers the whole of Russia, and that is why we, of course, cooperated closely with the Ministry of Healthcare, the Rospotrebnadzor, the Russian supervisor, and we were working actively with the neighboring regions, developing new measures. Now, what was the most important thing? First of all, we understood that we could be lacking medical professionals very soon. That is why we organized training for doctors to work effectively against COVID-19. The training involved experts from different domains, general practitioners, ophthalmologists, neurologists, and many other domains. Then we reinforced the staff of our hospitals by interns and students of our medical universities. We provided 4.8 million of packages of medicines to patients who were undergoing their course of treatments in the outpatient condition. We organized approximately 20,000 visits to patients, and we performed 14 million PCR tests. Then we organized computer tomography centers, 44 in number. They could accept up to 3,000 people per day. We performed the necessary examinations there, and then we defined whether we could treat this person in the outpatient mode or we had to accept the patient in hospitals. The ambulance transported over 520,000 people, and some of them were going to hospitals later on. We organized approximately 26,000 beds. Well, probably Moscow was better prepared comparing to other regions of the Russian Federation because we already had a functioning digital platform, and that allowed us to provide a follow-up for all the patients through all the stages, and in this way we were able to provide the continuous medical care. The results and the information was accessible to all the medical professionals, to the ambulance, to those working in the ambulance service in hospitals, and to the Russian supervisory service. We organized a separate module of information dedicated to COVID, and it is still accessible to all municipal hospitals and medical institutions. So all the information is collected in one database, and all the medical organizations have access to that database. So we have an up-to-date database for all the patients who are diagnosed with COVID-19 in Moscow. We also organized a unified digital register of all COVID patients. Now, during the pandemic, the various information and digital solutions were developing rapidly. We established a unified municipal telemedicine center, and that allowed us to provide for the dynamic follow-up for patients who did not have to go to hospitals. In those telemedicine centers, we were relying on the experience of the prior using of telemedicine, working with older patients.
Excuse me, sorry, Elena, could I ask you to try to finish. Thank you.
Хорошо. У нас были в первую очередь перепрофилированы уже отстроенные городские больницы.
So we had several hospitals that changed their profile, and there we added approximately 2,000 new beds. Right now, we continuously improve the measures that we offer to COVID patients. So we organized additional measures for intensive care units, and we also provide a special care to pregnant women who need to be hospitalized. We also organized remote diagnostic centers and multidisciplinary teams work with hospitals and the patients. In this way, we organized continuous medical care with a special focus on oncology patients. All oncology patients continued receiving the necessary health care, as some medicines for chemotherapy were provided to patients. Sometimes we performed chemotherapy in the outpatient mode. And in fact, we increased the number of oncology patients that we treat over here. We also provide vaccination anti-flu. We provide that in the premises of commercial organizations as well as in hospitals. We started vaccination from institutions, and we first offered it to senior patients, just like every other country. We also added additional tests to regular checkups. We perform X-ray examination and added tests to cover after COVID patients. We also organized small centers that were accessible to general population. So what are the lessons learned? Every patient matters. It is important to provide personalized approach, personalized care, and that allows us to tailor medical care to the needs of every patient. Then we pay special attention to prevention and vaccination. The reserve hospitals that we maintained throughout the pandemic allowed us to provide for continuous health care. Modern design solutions allow us to understand that we have to make our medical institutions universal. And in this way, on one hand, we can create additional reserves, and the improvements that we made over the time of the pandemic will be a good basis for further development. And of course, the digitalization of communication that allows us to talk today, for example, that helps healthcare too. That helps us to follow up patients and to perform all the interventions. Thank you very much. That is it on my side.
Okay, thank you so much, Elena, and thank you so much to all the plenary speakers. There have been so much nice presentations. I wish we had much more time to listen to you, but unfortunately we don't. So I think we will take the time for some questions. I see, at least if you can see the same chat as me, a lot of questions are being asked by the panelists, which is great. Let me see. We have a question here for Tom. Are you ready, Tom, to answer? Yes, we can see. Did you encounter vaccination hesitancy due to disinformation or fear skepticism towards a new vaccine? I think this is a very interesting question, and maybe some other also want to comment on how how can we prepare for this also in the future?
Mm-hmm. Yes, in different phases of the vaccination campaign, we had some skepticism. It was mainly focused on AstraZeneca and on a certain time, and also Johnson & Johnson. But we tried to use Pierre Van Damme or other vaccinologists, I hope I say it right in English, to counter this and to give information. Also on our website, we launched some campaigns for the older people, but also for the younger people, specialized at their targeting group. At the end of the campaign, when people realized that AstraZeneca was running out, because we started with AstraZeneca, but then the contract was ending, we ended with Pfizer and Moderna and Johnson & Johnson. They stopped. So there was more procrastination because they knew after the first invitation, we send the second invitation. So at the end of the line, so for example, when you're 50, you got your first invitation. And when we were through all the vaccination campaigns, just at the age of 16 or 12, it depends on the time, then you got a second invitation. And they knew at the end that it would be Pfizer or Moderna. So that we saw also, and with some specific religious or socio-vulnerable groups in the big cities, like in Antwerp and in Brussels especially. Yes.
Yes, thank you. Also, we have some questions here. They are in both Russian but there is a question to Elena. It says the telemedicine center provides remote dynamic monitoring of patients at home. Does it help to prevent the spread of the virus?
Да, конечно. Как мы знаем, любой
Yes, of course. As we know, all the virus diseases, if we do not let people to get together, if we isolate people, that helps us to stop the virus spreading. Telemedical centers, well, there we have highly qualified experts working. They provide a necessary follow-up for patients, and if needed, the patients are hospitalized, and this way they are protected. Thank you.
Thank you. And also a question for Tanya. Are you still here, Tanya? I hope so.
Yes, I am.
Yeah, nice to see you again. Do you have any information on how all, the important information and statistics and tools that you are providing, how much they are used by the countries?
Yes, so there's different differences here. So we have our COVID-19 dashboard that has been launched since the very beginning of the pandemic, which also includes information on cases, also more recently on vaccination data. So this is actually one of our most visited sites. I think the latest was 300,000 views. So we are collecting that data. Within some other side products like the calibration tool that I have mentioned. So that is a process that has been ongoing for some time, but we just recently had it as an online tool. So it is really at the beginning phase. I don't have data on that, but I would really recommend and I can put the link into the chat to have a look, as it is a very practical tool on that side. And on the question of vaccination, I also added a link to our joint WHO ECDC bulletin that is published on a weekly basis, where you will have up-to-date information on vaccination uptake as reported to WHO and ECDC.
Okay, thank you. Also, Lydia, I wanted to ask you, you have got a lot of questions about suicide on the chat. Would you maybe comment more generally on that? Lydia, are you still with us? No, she isn't. Okay, and unfortunately, Melita has also left, so I don't know if we have the results of the poll available. Not to my knowledge, but maybe we can get a hand of it and come back to that.
Yeah, we will send it, part of the, tomorrow we hope with the results of day 2. Okay?
Yeah, fine. So we are now shortly going in for a short break. But first, André will inform you a little bit about the next session.
Да, для тех, кто еще не определился, какую из...
Right. For those who are still unsure about which panel discussion to go to, I would like to remind that you have 3 of those. The first one will be on health equity and health system strengthening. The moderators will be Dr. Sara Darius-Kurve, and I will be helping her. The second panel discussion will be on healthcare systems and society resilience, and here the moderator will be Volin Solvik, and workstream number 3 will be about lessons learned from COVID-19 communication. And here, well, I think that the last topic about the lessons learned, please keep that topic in mind as a question to actually all the 3 groups of panelists. Because after the work streams are over, we're going to get back together for the closing plenary, and we'll discuss the results of every work stream. And then we will listen to the final keynote speech, and we'll look at the results. And now we'll have a short break, 5 minutes, and I thank all the participants for your work. Thank you.